Let people in. This is the fun part because we start seeing how many people are gonna just pop in.
I got a notice before that there were 22 people signed up.
22? There are 200 now.
No pressure, Iris.
22. And I think because too, this is LDS and VEDS, so it's a bigger mix of people.
Katie, I forgot to ask you, the Q&A, are you kind of reading the questions out to us to answer, or are other participants doing it? Okay.
No, I'll be reading the questions to you. And do you guys have a pattern of who answers what, or I'll just ask both of you and one of you answers? Or?
I'll take the lead, and if Dr. Camilleri has something to add, he'll kind of add at the end. But we did work together to prepare some answers for the ones you sent. So I have something to say for everything.
Oh, good. Okay, that sounds great. So far we have one attendee. It's a little early. Hello, Anne. And there is a chat in Huva as well. So go and say hello to people.
It's a really beautiful day in Minnesota today.
Is it?
Yeah, it's not humid. We have lovely warm weather, but not humid. So it's been a change because we've had some very hot and humid days.
What is cold? Or what is warm, I mean?
Warm now is 75.
Oh, that's great. That sounds really perfect.
Yeah.
It's kind of very muggy in Florida this weekend. Lots of like scattered showers from the edges of Florida, and lots of humidity because it's August. So, and that's just unfortunately the way it is here. But 75, I'm very jealous of. Sounds wonderful right now. Very, very nice. Got 2 people. Hello, Kristen. Welcome. Oh, Bruno, I'm getting a little note that my internet connection is unstable.
Ooh, okay.
I don't know. Hopefully it won't be a problem. Do you want to switch?
Yeah, if you
I
want.
want to see how it goes.
All right, 1 second.
Want to make sure you have no problem.
You just. So I'll just follow your script, I guess.
Okay. That sounds good.
All right.
Oh, I lost the panelist. Oh, there it is. It's at the bottom now. There we go. Now I can still see everybody. This will be our first Saturday one, I think. So it'll be interesting to see how many people are going to be fighting the 75-degree Minnesota weather to join us.
Iris was concerned I was going to be on my ride-on mower.
You were going to be on your mower, you said?
Yeah.
With the pandemic, there hasn't been a lot to do here where I live, and I actually joked with my husband that it would be nice. He has an old ride-on one that he uses just to like move stuff around the yard with a little trailer on it. I'm like, you just like let me ride that around the yard sometimes. I'm bored.
Actually bought a kayak a month ago just to do something here, so I'm gonna probably take that out as soon as we're done.
I love kayaking so much.
I'm not very good at it. But.
No, it's like there's a certain way to do the paddle just right. And you use the paddles need to be like 90 degrees apart.
Oh, okay.
Like so that they're angled like this.
Oh,
and that helps it cut into the water at the right angle. And then you really just got to do like a round, like, but you want to try to like slide it into the water very smoothly, and that will give you the most like.
Oh, that's really
Oh.
helpful.
It's
Because
a
right
lot
now, my kayak kind of goes like this.
of fun. What kind of kayak do you have?
I got an inflatable one.
Oh yeah.
A very good introductory kayak, as I drive a Honda Fit and can't have a real one.
There's a, I used to have a Honda Fit with a kayak, and I put a kayak on top of it a couple times. I had an inflatable roof rack. So you just put the inflatable roof rack on the top, and then you put the kayak on the top, and the Honda Fit's pretty short, so you can actually do that as somebody my size. But I actually upgraded to a lighter weight kayak that's foldable. So it's called an Ori kayak, and it folds in and out. So it's a 11.5 feet, I think, long, and it's very light. It's only 25 pounds, and it folds into this like giant box that's about as big as I am. But I love it. It's very lightweight. When I was a teen, I would throw that 55-pound kayak on top of my 4Runner. I had a Toyota 4Runner. And I would just throw it up there by myself, tie it down, and go out for 8 hours, and no idea I had beds. It was crazy. But it was a lot of fun. I really enjoyed it. Huh?
Now you got to be a little more careful.
Yeah, although nothing ever happened while I was doing that. So I got very lucky, or it didn't matter. I don't know. But I think I just got very lucky, and I was younger. But it is really enjoyable. So I hope you have a lot of fun on yours and get into it. I do know the inflatables do move around a lot. They're a bit challenging. So congratulations. All right, we have more people joining. There's about 6 now. Hey, Fran. Hey, Danielle. Hey, Chris. Chris is all the way from New Zealand, I think. Dana, Trisha, I remember seeing her in the chat. Michelle. Hello, everyone. Welcome. We're going to get started in a couple minutes. We're just talking about kayaking and weather, and grateful that you're joining us on a Saturday. Hopefully you're not competing with nice weather. But we'll have a lot of fun. Or it'll at least be very educational. I don't know if fun's the right word. It's fun for me. We've got about a minute. $11, $12. Oh, there's Deborah Niaspaziani again. Hi, Deborah. Guess I should check the chat, make sure nobody's saying hi to me in there. Let's see. Oh, Kristen Peterson is also a kayaker. Michelle says it feels like 110 in Florida today. I totally feel you. I'm in Florida as well. I do see some questions coming in the Q&A in the chat box. Make sure to put these in the Q&A box. That's where we'll be monitoring for questions. I think Ying put a question there. So Ying, if you could put your question in the Q&A box, that'll make sure that we are able to see it during the presentation. And I guess it's 12 o'clock, so we can go ahead and get started. Welcome, everybody. My name is Katie Wright. If you don't know me, I'm the director of the VEDS movement, a division of the Marfan Foundation, specifically for people with vascular Ehlers-Danlos Syndrome. We're really excited to have you join us in this International E3 Summit. This is the very first time that we're having one, educating, empowering, and enriching our community. This is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. So we're really, really grateful. We're also very grateful to our presenting sponsors, Brigham and Women's Hospital and American Communications Construction, for helping us bring this to you today. Before we get started, I would let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. As such, opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or of the CERN. And before we move on to the presentation that Dr. Wang prepared, I would like to give an opportunity for Dr. Wang and Dr. Camilleri to both say hi to you today. We're very excited to have them join us and give this presentation and Q&A. So thank you both for joining us. And do you want to say hi to everybody?
I can go first. Hi, everyone. I'm Dr. Iris Wang. It's really an honor to be here to chat with you and share with you some of our work and our experience in the GI field with these conditions. So I look forward to answering some questions in the Q&A session.
Thanks. I'm Dr. Mike Camilleri, and I work with Dr. Wang. And we've been studying these conditions in the last few years, and we have learned a lot from interactions with your foundations already. And we look forward to Dr. Wang's presentation and the questions that you'll be posing. Thank you.
Thank you both. So I think now we will move on to the presentation. If you have any questions during the presentation, please put them in the Q&A box. We will have plenty of time at the end to go over questions, and we will get to as many as we can. So now we're going to turn off our video so that we can focus on the presentation that Dr. Wang prepared.
Hi everyone, my name is Dr. Wang. I work with Dr. Michael Camilleri, and the two of us are very, very excited to be presenting to you some of our work. We've titled this talk Gut-Wrenching, GI Symptoms in Vascular EDS and Loeys-Dietz Syndrome, or LDS. And I really thank the Marfan Foundation for inviting us to give this talk. We're very excited. So the outline of our talk is going to be a brief word on vascular EDS and LDS. Why are there GI symptoms in these disorders? What are the common symptoms that are seen? And what are some ways to manage these common symptoms? Lastly, we want to share some things to watch out for in GI conditions that are involved in these disorders. So a brief word, and I know all of you are well aware of these disorders and you've had some great experts talk about these other things. Just as a background, Ehlers-Danlos Syndrome is a defect in collagen synthesis. The GI symptoms are commonly associated and known to be associated with a hypermobility subtype of EDS. Some of these symptoms are hernias, gastritis, abdominal pain, distension, nausea, vomiting, reflux, and constipation, including evacuation disorders. Vascular EDS is less well known in terms of the GI symptoms, but we've seen similar symptoms as hypermobility EDS, plus this risk of colonic rupture. Loeys-Dietz syndrome is a disorder of genes in the transforming growth factor beta, or TGF-beta pathway, which leads to extracellular matrix disruption. What this really means is that the essence and matrix that holds our cells in place and next to each other is disrupted, leading to similar weaknesses as defective collagen, because collagen also serves a similar role to provide structure to our cells. Loeys-Dietz syndrome predisposes to allergic diseases because of that TGF-beta pathway and the multiple things that that pathway is involved in, and can present with vascular tortuosity very similar to VEDS, and has a phenotypic overlap with not only VEDS, but also Marfan syndrome. Before we show some pictures of abnormalities seen in these conditions, I want to show you a normal angiogram. So what we're noticing here is really a very straight aorta coming down with multiple branches of other vessels coming off that aorta. You can see that everything kind of looks tubular and, again, straight as an arrow with that bifurcation with where the common iliacs break off. This is the imaging of a 44-year-old woman with vascular EDS. What you're seeing on the left is a reconstruction of a three-dimensional CT scan. And what you're seeing that's different from that previous straight arrow picture is a lot of what we call tortuosity or bends and kinks in those vessels, particularly at that break-off or bifurcation where the iliacs break. What you also see is on the picture labeled right side, so actually on the left side of the picture, you see a line running through this common iliac here. And what that is a dissection in that vessel. You can see the same similar picture of a dissection as where that blue arrow is pointing, and that darkness inside the bright white vessel is a dissection of that vessel where the lining is actually tearing. Here's another patient with VEDS, and what you're seeing here is the abdominal aortic aneurysm, which is that ballooning or out-pouching where there's weakness in the vessel. And you also see a common iliac aneurysm down below. On the right is that CT scan from which the left-sided picture was reconstructed from. And you can also see this big balloon dilation here. Loeys-Dietz syndrome, again, you can see a very similar phenotype. You see that the vessels, instead of coming down that aorta, is making twists and turns and looks relatively winding instead of a straight, narrow road coming down. And you can see some ballooning after that bend as well. So what are some GI symptoms in vascular EDS and LDS? First, why is the GI system even involved? We know that there's a lot of vascular involvement, joint involvement, but often the GI symptom involvement is overlooked when people first think about these disorders. Well, the collagen and extracellular matrix defects really affects tissues throughout the body and can contribute to tissue fragility in the intestines themselves. That structural instability can lead to pelvic organ prolapse because of weakness of the diaphragmatic muscles holding up those organs, which can lead to pelvic floor dysfunction and cause constipation or even incontinence. There's also an increased risk of organ rupture, including the intestines, because of that tissue fragility. The impact of those tortuosity and dilation of vessels can actually compress the nearby intestines and cause issues. Impact of IgE, eosinophils, and TGF-beta in the GI tract can lead to various allergic manifestations and also gastritis, esophagitis, and other more immune-mediated abnormalities. And lastly, these are chronic diseases that have a lot of psychological burden on everyday life, as patients and family members are well aware. And this burden of chronic disease has been documented to lead to disorders of the gut-brain axis and visceral hypersensitivity. And what that means is really that the function of the bowels through the nerve become altered because of changes and differences in nervous input from the central nervous system and the interaction with the enteric nervous system. And so the burden of chronic disease and having symptoms of depression, anxiety that develop around the chronic disease can lead to bowel dysfunction or worsen underlying bowel dysfunction. So what symptoms are seen? Dr. Camilleri and I performed a retrospective review looking at all the patients that we've seen at the Mayo Clinic with vascular EDS and LDS over the past 10 years or so. We looked at 68 vascular EDS patients and 13 Loeys-Dietz syndrome patients. You can see the distribution. About 60% of the VEDS patients were female and 40% of the LDS patients. Age at diagnosis averaged about 40 years old for vascular EDS and 33 years old for LDS. And you can see that about 57% of our VEDS patients and 33% of our LDS patients had undergone prior abdominal surgery. And we'll get into the details of that a little bit later. We looked at all the upper GI symptoms that were reported from these patients at their visits to GI, to genetics, or anywhere else. And I bolded a couple of the symptoms that were very commonly seen in this group. One was nausea. Heartburn and reflux was commonly seen, more common in LDS than VEDS. Abdominal pain was very common in both groups. And bloating was common as well, though not as common as the other symptoms I've mentioned. Interestingly, I want to point out this eosinophilic esophagitis, which I know we just mentioned the eosinophils, and that's going to be it's going to come up a little bit later in terms of importance in LDS. The lower GI symptoms that we saw included constipation and diarrhea as the most common ones reported, and these were more commonly seen in LDS compared to VEDS. A prior study from our group looked at gastric emptying and colonic transit, and these are studies that evaluate the function of the GI tract and how it moves. On the gastric emptying study, you can see that a large number of patients fell outside the normal range, either early accelerated gastric emptying or delayed gastric emptying. And delays in gastric emptying are what lead to gastroparesis. Early accelerated gastric emptying can lead to problems as well if there's too many nutrients reaching the small bowel too quickly. But the one that we know causes issues is going to be that delay. On the colonic transit side, we also see a wide distribution outside of the range of normal. Delays in colonic transit lead to constipation because of slow transit, but acceleration in colonic transit also leads to issues in the form of diarrhea. In the literature, there's been reports of severe inflammatory bowel disease associated with these congenital alterations of TGF-beta. So these are going to be associated with LDS syndrome. The case reports we found were a 13-month-old female child with LDS that developed chronic bloody diarrhea and was found to have an ulcerative colitis-like picture on colonoscopy evaluation. And she was found to have a TGF-beta R2 mutation. The second case report was of a 26-year-old male child with LDS that developed ulcerative colitis, and he had a de novo TGF-beta R1 mutation, so his parents were not involved. Other things that we looked at were the rates of hernias, because we know from tissue weakness that, from the underlying tissue weakness, that patients with EDS are at risk for hernia development. So in vascular EDS, hernias were present in about 50% of the cases we looked at, and it was a similarly high percentage in LDS syndrome. And the important thing I want to point out too is that a lot of these were post-operative hernias. And we know that patients with EDS and LDS often do require a number of surgeries, particularly for repair of vascular malformations. And so post-operative hernias is going to be a big concern. And you can see that 66% of our VEDS patients develop those hernias post-operatively. And that's 66% of those who had hernias. So 66% of the hernias were post-operative. Recurrent hernias were also an issue, and you can see that 22% and 33% of those hernias were recurrent after attempted hernia fixture in VEDS and LDS respectively. What imaging studies or gastrointestinal investigations were done in this population? Well, you see that imaging studies were performed fairly frequently, with 80% of our VEDS and 90% of LDS patients undergoing imaging. And of the ones that did get imaged, you see that 91% of VEDS patients who got the imaging study had an abnormal finding. And 100% of the 12 patients who underwent imaging studies in the LDS side had abnormal findings on the imaging study. A lot of those were vascular abnormalities. Some of them were inflammations, hernias, etc. In contrast, very few patients undergo upper endoscopy and colonoscopy, which is actually a good thing because that's what the guidelines say. But what's important to note here is that only about half of those upper endoscopy or colonoscopic evaluations were abnormal, meaning that it's okay for half of those patients to have not undergone those studies because they were normal. What were the surgeries that were done? Well, we wanted specifically to look at surgeries that were done for GI complications. And here you can see rates of colectomy and small bowel surgery in our patients. Not very high, which is encouraging. But a word about GI surgeries in VEDS. There's a 27% incidence of spontaneous intestinal perforation, and that goes back to weakness of the intestinal wall from that collagen defect that we talked about in an earlier slide. 47% of VEDS patients present with colonic perforation as a first gastrointestinal symptom. So not nausea, not bloating, not pain, but actually perforation was the first GI symptom they had. And this is seen in the literature. Reperforation rates were as high as 41 to 53%. So once that first perforation happens, and once you repair that tissue, it becomes more likely to perforate again. And the risk of perforation during an endoscopic procedure is as high as 9.4%. So not as high as spontaneous incidence, but also a very high rate compared to our normal risk of perforation in the general population, which is about 1 in 2,000. What does that look like? Well, this is a case of a spontaneous perforation followed by rupture of a cystic artery. And what you're seeing here is hemoperitoneum, which is blood filling the middle of the peritoneal sac and a ruptured artery. And on the right is the histology micrograph showing the tear in that artery. Comorbid conditions can be seen as well. And so we looked at what other conditions are seen in our cohort in addition to the GI manifestations. The ones that I want to point out to you are autonomic dysfunction, which is that sensation of feeling dizzy when you stand up. Orthostatic intolerance, if you're not drinking enough water, you get dizzy very quickly or even faint. And you can see that that's more common in our LDS population that we looked at compared to VEDS. And that p-value is significant because there was a significant difference between those two. Psychopathology, and pointing out, and what we define as psychopathology would be anxiety disorder, general anxiety disorder, and depression. Because of that burden of chronic disease and what we know about the relationship between the central nervous system and the enteric nervous system in the gut-brain disorder, in the disorders of gut-brain axis. And lastly, what I'm pointing out here is the peripheral blood eosinophilia and the allergy. We see that there is a higher rate of allergic disorder in LDS because of what we mentioned in our earlier slide, that the TGF-beta pathway is linked with allergic disorder development. And we see that to be true in our cohort, where we see that the LDS population has a high rate of allergy. However, there's also this concern that there's a high rate of eosinophils, which is sometimes involved in development of an allergic response, and can cause GI disorders like eosinophilic gastritis or eosinophilic esophagitis. However, in our brief retrospective evaluation, we didn't find any increase in peripheral blood eosinophilia. So we didn't see that suspected relationship with eosinophilia increase in LDS. And we had kind of briefly touched on that earlier in one of our early slides. So to summarize our findings, we saw that VEDS and LDS are both connective tissue disorders with a propensity for GI symptoms, hernias, and aneurysm formation. That LDS patients had more issues of bowel disturbance with diarrhea and constipation, but our VEDS population had more abdominal pain. VEDS patients had more ventral hernias, and that's hernias of the outside lining of that stomach, and postoperative hernias compared to our LDS patients, who develop more inguinal hernias, which are lower down and not at the abdominal wall like the ventral hernias are. There's a risk of arterial rupture, and their comorbidities of autonomic dysfunction, psychopathology, and allergy are all seen to be greater in our LDS population than the VEDS population. What are some limitations here? Well, a lot of the findings that I'm presenting to you, everything in the tables, was from our retrospective review of our patient population. And that suffered a lower sample size, particularly of the LDS patients, because we only had 13 patients with a true diagnosis of confirmed LDS that we were able to query. It was a retrospective review, which means that patients may have had symptoms, but not reported them to the doctor at the time of visit because of other things that had come up at that visit, or thinking that the symptoms were probably not bothering them as much as other issues. There was limited diagnostic testing because of the risk, but because of that as well, we don't know what we would have found otherwise. And so what we proposed for the future direction, what we would really like to do is have a prospective query of patient symptoms, where patients who do have documented LDS and VLDS report symptom development as it's happening, and we can have a database of those symptoms and the workup that's undergone in real time, so that we're not suffering any recall bias or missing any of that workup like we may in a retrospective review. So maybe what you care about more, instead of what GI symptoms are there, is how do we manage those symptoms? Well, the baseline here is going to be we manage the symptoms by discovering what is causing those symptoms. Gas, intestinal, and abdominal pain can be caused by a number of reasons. A large driver of these symptoms is actually going to be constipation. So is there constipation? Well, we'll get into how to treat that in the next slide. Is there inflammation? Is there gastritis? Is there reflux? Well, the first thing to do there is going to be to control acid, mostly, largely with PPI treatment or protonics, pantoprazole, that kind of medication. We test for H. pylori infection, and the best way to do this is actually going to be a stool test because it's the simplest and least invasive. We want to avoid any offending medications such as our NSAIDs, and we'll talk about that a little bit later. Is there a disorder of the gut-brain axis? Things like IBS, functional constipation, functional dyspepsia, and we can treat those with targeted medications as well. And I don't want anyone to get the idea that these are disorders that are just in your head or because of anxiety or because of depression. These are a group of separate functional GI disorders that we know are alterations in gut function that we just don't have great testing for at this time. But they are separate disorders that we treat with separate medications, and they're not just in your head or driven by any any psychological issues, which patients can sometimes hear. But again, I want to reiterate that these are a separate condition of GI pathology on their own that are just linked to disturbances in the CNS or central nervous system. So if there's constipation, we usually want to start with a therapeutic trial of fiber and osmotic laxatives. So fiber, we recommend greater than 12 grams per day. And the osmotic laxatives that we generally recommend are going to be Miralax or milk of magnesia. Otherwise, if those don't work, there are prescription medications for constipation, including the secretagogues, and that's going to be things like Linzess or Trulance. And then stimulant laxatives, some of them are over the counter, like Bisacodyl. Suppositories can be used, but there is importance to note that if you're going to use an enema, that it should be under supervision because sometimes it can lead to increased pressures in the rectum and risk of rupture because of already fragile tissues. So be careful if you're thinking about an enema, but suppositories can be used if it's a gentle suppository. If there's no benefit from fiber and osmotic laxatives, we would look for pelvic floor dysfunction. And we know, particularly in the hypermobility subtype of EDS, that pelvic floor dysfunction is very common because of weakness in those muscles and ligaments of the pelvic floor. And if there is pelvic floor dysfunction, we would recommend physical therapy in order to treat that condition. If there's no response to recommended treatment, we would want to look for alternative causes of constipation, particularly looking at medications that can cause constipation, like calcium channel blockers, which can be used to treat hypertension, or certain antidepressants can cause constipation as well. Other than that, we can do deeper evaluations of colonic motility, including with the colon transit studies that you saw in a study earlier, or with even colonic manometry studies. So those we have to be very, very careful with because they have to be done with a flexible sigmoidoscopy, and there's a risk of a procedure and risking of perforation. Upper GI symptoms after meals can be due to gastroparesis, which, as we saw previously in that gastric emptying study, can be pretty common, particularly in hypermobility EDS. So we want to evaluate for slowing of gastric emptying. And if it's present, what we recommend is what we call small blenderized meals. So that means meals that look like or have the consistency of having been through a blender, or actually putting your meal through a blender and eating it that way, because that's going to help the meal empty the stomach faster. And then separating eating and drinking is going to be really important, because drinking can alter the way gastric emptying happens. And so we recommend drinking liquids at least 30 minutes after eating to avoid upsetting gastric emptying. What medication should you avoid? NSAIDs are going to be a big one. These are ibuprofen, Aleve, Motrin, etc. These can lead to gastritis, can lead to ulcers, small bowel inflammation, and abdominal pain. Narcotic pain medications are going to be trouble as well, because these can lead to severe constipation, which can lead to backup ileus, which means slowing of the bowels, and distension of the bowels, which you really want to avoid, because it will increase risk of perforation by putting more pressure on the bowel walls. What are some other important things to know? Well, you really want to play it safe. Looking at the vasculature of the arteries is going to be really important. Screening for aortic root dilation, mitral valve prolapse, especially because these can be done non-invasively through CT scans, MRIs, ultrasounds, etc. So it's important to follow up with your doctor's recommendations to get screened. You want to monitor for nutritional deficiencies if there are any GI disturbances. So if you're having a lot of diarrhea, a lot of constipation, or trouble eating, it's important to look out to make sure the vitamin levels are appropriate and that the caloric needs are being met. We want to avoid trauma, collision sports, other activities, and actually avoid routine colonoscopy or elective surgery. And that's because of that almost 10% risk of perforation with endoscopic procedures that we saw. And for elective surgeries, there's always the risk of that hernia of being a risk post-operatively. But if you don't get routine colonoscopy, what are some alternatives? Well, the Cologuard test is actually one of the safest that you can do, because it's testing just by a stool sample. And the Cologuard test looks for not only fecal blood, which can indicate a cancer or a large polyp, but also changes in fecal DNA, which can indicate polyp formation. But a quick word here is that Cologuard testing can have a lot of false positives, because the testing is designed to find any small thing that could be cancer, because we really don't want to miss something. And so in that catch, you could find a lot of things that aren't cancer, but give you that positive test. So even if your Cologuard is positive, you don't want to be too worried or too stressed. You just want to undergo follow-up testing. The other thing that you can think about is a CT colonography. But even with this test, they need to blow a lot of air into the bowels. And like we talked about before, that increases pressure on the walls. It does also increase the rate of perforation. So that can be considered if you need it. But we would recommend more non-invasive testing, like with testing of stool samples. But that asterisk is there to remind you that the Cologuard is really developed for folks that don't have any increased risk. So anyone with increased risk, like a family history of colon cancer, may actually need to pursue more invasive screening procedures anyways, in order to make sure that we're not missing anything because of that increased risk. So with that, I'll thank you for your attention. This is me on the left and Dr. Camilleri on the right, and we'll be happy to field questions.
Thank you so much, Dr. Wang, for preparing that presentation, and Dr. Camilleri for joining us for the Q&A as well. I know we're very excited to get to the Q&A, and there are a lot of questions in the Q&A box already. I'm going to go ahead and, let's see, get Dr. Camilleri back on video. Dr. Wang, if you'd like to unmute yourself, you can do that too. And it looks like I can only spotlight one of you at a time, but I think it'll switch off hopefully just fine. So our first question was actually submitted, I think, before the Q&A box opened. So I'm going to start there. for somebody, I think this was somebody with VEDS, but can probably be applicable to anybody who has an ileostomy. What are the guidelines for ileostomy care? And is there anything else that should be considered in relation to ileostomy care other than VEDS? How often should they be following up with a GI physician?
So I'll start by saying that each individual ileostomy is going to, have individual circumstances. So throughout this Q&A, know that we're giving kind of general information from the literature that may or may not be applicable to an individual case depending on their circumstance. So that being said, in terms of overall ileostomy care, what we generally like to do in terms of teaching is making sure that you understand care of the skin and care of the stoma. And so making sure that any appliances that are used fit the stoma well, that there are appropriate barrier creams so that if there is contact of any of the contents that come out of the stoma with the skin, that there's appropriate protection of that area. Making sure that there's no allergies to the adhesive that's used in those ostomy products. And then monitoring really for ostomy output. So what we mean by that is estimating how much is coming out of that ostomy on a daily basis and knowing what to expect. So immediately after an ostomy is created, you may expect actually more output as your body adjusts to having an ileostomy. Eventually, a couple of months to years down the line, that ostomy output should really come down and be less than about 1.5 liters a day. And so that's the benchmark with a long-term ostomy in terms of if there's more than that kind of output, then we want to make sure that you're not dehydrated, that there's not something else going on. Specifically for VEDS patients, we talked a little bit about hernias in the presentation. There hasn't been a study really of ostomy-related hernias, but those can happen. And so monitoring the area to make sure that there's no excessive bulging, that the ostomy is still looking healthy, that there's not outpouching of the ostomy that may be concerning for a hernia would be important to monitor in the VEDS population.
Okay, thank you. Thank you very much. So for the next question, we've got a lot of upvotes on this one. Are specific categories of foods a large contributor to GI motility? And if diet is not a large contributor, what are the most frequent contributors to GI motility and slow transit?
Diet does play a big role in GI motility. So 2 large components of the diet to think about are fiber and fats. So fiber's role in motility is really bulking up the stool. And so that bulking of stool can really help improve motility if there's adequate hydration. So making sure to drink enough water along with your fiber will help stimulate the bowels to move. So that's why, you've heard about warm prune juice as a potential for helping constipation in elderly populations, for example. That's because it's basically the perfect combination of fiber and water to help stimulate the GI tract. Now, fats are a little bit of a different story. Fats matter a lot if there's slowed upper gut motility because fats will delay gastric emptying. And so if there's a problem with feeling very full very quickly, not being able to eat a lot of meals, or feeling like food is staying in the stomach, or a diagnosis of gastroparesis, then we'll actually recommend less fat in the diet because fat is really what holds the food inside the stomach and can delay that emptying. On the flip side, if you feel like food is running through you a little bit too quickly, then maybe increasing the fat can help a little bit with that. Other things to consider in the diet are things that are non-digestible and non-absorbable sugars. So things like sorbitol, xylitol are in a category called polyols and are frequent components in things like sugar-free gum, anything labeled diet or low sugar that still tastes very sweet. These are the synthetic sugars. And because our body can't break them down, they end up pulling a lot of fluid into the GI tract and can cause a lot of symptoms in terms of diarrhea. Other things like fructans and galactans are different components in the diet that also our body can't break down. And so then we rely a little bit on the colonic bacteria to break these down. And when the colonic bacteria break down our sugars for us, they can make a lot of gas and can cause a lot of cramping symptoms. So that can actually increase the motility of the gut, but in a way that you may not necessarily want. So watching out for things like raw garlic, onion, beans, some of the wheat-based products have a lot of fructans in them, and so can cause a lot of symptoms as well. Beans, lentils, things that are classically known to generate gas can produce some symptoms.
Thank you.
So let me just add to that, to link to the first question.
Dr. Camilleri, it's a little hard to hear you. Move closer to your microphone.
Okay, can you hear me now?
Yes.
Okay, sorry. I just want to link that last answer to the first question as well, because often there's a problem in patients who have an ileostomy when they take fluids that have artificial sweeteners. Okay, so if the ostomy output is high, check on what are the liquids or the fluids that are being ingested, and that may be a very simple change, just to link it to what Dr. Wang was saying. Simple change is to reduce the intake of artificially sweetened drinks, which can cause more diarrhea and increase the ostomy output.
Thank you. For our next question, what are some red flags that indicate when somebody with LDS or VEDS or even Marfan syndrome should see a doctor about their GI symptoms?
We always worry about sudden onset abdominal pain, and these symptoms may come with chronic abdominal pain, and so each individual is going to know their symptoms best. But if there's a significant change in the degree of that pain, increase in severity, or a sudden onset of something new, that's always going to be a red flag to get checked out, especially because of that risk of perforation or a vascular kind of catastrophic event. If that abdominal pain is also comes along with lightheaded, dizziness, feeling faint, that's a big red flag to seek emergent care. Kind of moving down the list from something so big and catastrophic, anything that involves blood coming out of the GI tract, either from an ostomy side or from below. And again, especially if there are symptoms of lightheaded, dizziness, that's something to seek care for. And if there's a little bit of bleeding, sometimes it's because of hemorrhoids, and you know your body best. And sometimes you can tell if it's just a little bit on the toilet paper. That's not the type of bleeding I'm talking about. It's more kind of blood mixed in with stools, or bright red blood in a large amount, black tarry stools, those we do really worry about. And then lastly, any change in the ostomy output. Is there suddenly way more ostomy output than you expected, or on the contrary, has your ostomy stopped putting anything out? Then those are times to seek care.
Thank you. For our next question, man, we have a lot of questions here, and we will get to as many as we can. So we're just gonna keep on going. Is delayed colon motility a common problem in Marfan syndrome, and has much research been done on GI involvement with Marfan syndrome? Do you know if there are any common issues like that?
There are, there's been actually a really great study that was done out of the Brigham group that's sponsoring this event. They did a really great national cohort survey study of Marfan's patients, EDS patients, and they looked at all the subtypes of EDS. And the good news is what they found was in Marfan's, the prevalence of things like irritable bowel syndrome, functional dyspepsia, heartburn was about half that of the EDS population. So while they're still a little bit more common than the general population, it's much less frequent than in VEDS or in hypermobility EDS, for example. I don't know that any motility studies have been done in that Marfan's population. I didn't see any. I'll kind of see if Dr. Camilleri knows of any, because that large cohort study was based on survey symptoms. It's hard to really study motility because it does involve a little bit of extra testing, and some of that does increase risks. And so I'm not sure that data is out there.
Yeah, I would agree, Iris. I don't think there has been much of a of an investigation of the motility in patients with Marfan syndrome. But keep in mind that even in the general population, up to 20% of the general population in adults have constipation. Up to 30% have weekly heartburn. So there are common symptoms that occur even if you don't have an underlying Marfan, VEDS, or Loeys-Dietz syndrome. And they can be treated, just as Dr. Wang is mentioning, these disorders of the brain-gut axis, for which there are some very specific treatments that can be provided. So by all means, our patients should all discuss these common symptoms with their physicians, their gastroenterologists.
And Katie, if I might add, in the study that the Brigham group did, they actually looked at pelvic floor dysfunction. And I think I saw some questions in the Q&A coming in about pelvic floor dysfunction. And I think it's not commonly known that pelvic floor dysfunction, in addition to causing constipation, can actually slow motility in the entire GI tract. And so it can actually be a huge contributor of slowed motility and is really important to treat, because if that's present, a lot of the other treatments for constipation and other GI symptoms will not work as well if we don't fix that underlying issue. And that prevalence, just to quote their paper, was 83% in the EDS population and 66% in the Marfan's population that responded to that survey. So it involves quite a lot of the patient.
Wow. And that was the EDS population as a whole for that paper, right?
Correct.
Okay. Just wanted to make sure.
Yep.
So the next question is, and I will look for that. I did see that pelvic floor question in the Q&A, so I'll look and make sure that we answered that one. Can diet play an important role in avoiding ruptures of the intestines in patients with VEDS?
From our, when it's hard to say, it's not like, there's been case reports that if you get a chicken bone stuck in your throat, yes, there's an increased risk of perforation, but that's kind of for all comers. In terms of for increasing the specific rate of spontaneous perforation, there's no data driving this, but from a physiological standpoint, we really want to encourage avoiding straining and avoiding constipation, which is hard because that's a big problem in these disorders. But what happens with increased straining is increased pressure in that abdominal wall. And with constipation, especially if it gets more advanced, the bowels can dilate and put a lot of stress on the wall. So those two factors can really increase or increase the fragility of the bowel wall and increase the rates of perforation. So we would advise dietary means to avoid constipation.
So that would be avoiding any foods that might irritate your own system, and
Correct.
also the other methods that you talked about in the presentation.
Correct.
Great. Can constipation or intestinal issues be a cause for fatigue?
It can. There's not a clear, there's, how do I phrase this? It's hard to say that it's just the constipation that's leading to the fatigue, but we know that there's a kind of spectrum of the disorders of the gut-brain axis that kind of involve what's called a central sensitization syndrome. And this involves groups of disorders like irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia, that often all come together and have overlapping symptoms because they're all related to a dysregulation of the input from our peripheral nervous systems into our central nervous systems. So it's not necessarily that the constipation can cause fatigue, and certainly it can if there's a lot of issues with straining, needing to use the bathroom, alterations in lifestyle habits, but it's more that it can come along the spectrum of central sensitization and have overlapping symptoms with the other disorders.
Thank you. And let's see, a lot of good questions here, a lot of good questions. This is a really good one, I think. We talked about avoiding constipation to avoid that or lower that risk of intestinal perforation or rupture. Could you talk a little bit about the signs of a perforation or rupture? I think you did talk about that sudden pain, but just to make sure everybody really knows what to look out for.
Yeah, so rupture, even though it sounds very catastrophic, can be a very large and catastrophic event, but also can actually happen on a more microscopic basis. And so that large, sudden abdominal pain, that's kind of the life-threatening large perforation that needs to be treated right away. Other things can also happen called microperforations, where there's just kind of a small leak. And I noticed some folks in the Q&A have maybe mentioned that they have history of perforation that's healed on their own or not required surgery. And that's those micro or smaller perforations where our body actually is able to catch the perforation and contain it. But the problem with containing a pocket of perforation is that there is still some leakage of bacteria, intestinal content into whatever your body has walled off. And so it can still cause an abscess and symptoms of infection. And so in addition, if you don't have sudden abdominal pain, noticing new abdominal pain along with symptoms like fever, aches, generally feeling unwell with concomitant abdominal pain, that's a reason to go and have cross-sectional imaging to make sure that there's no abscess that's formed. Sometimes if these perforations happen near other organs, you can actually form fistulas. So having kind of symptoms of air or stool leaking into the urine or into the vaginal vault should be a big concern, although I don't think anybody would dismiss those symptoms easily. But those would be the other kind of non-large catastrophic findings that you may want to watch out for. So fever, abdominal pain, and bleeding or finding fecal matter elsewhere.
Okay.
So
Yeah.
one other comment. So I don't want people to be their own doctors, but in the context of abdominal pain, if there is fever, as Dr. Wang mentioned, that's always a bad sign. But if the patient or the mother or the father places a hand on the abdomen where the pain is being experienced and there's tenderness, or even worse, if there is what we doctors would call rebound tenderness, that is, the pain is actually worse when the hand is taken off the abdomen, that's a sign that there may be peritonitis, that there may be an important perforation that we can't assume is going to seal itself. Okay, so just think about that rebound phenomenon. And if there is more tenderness when the hand is taken off, then please visit the doctor urgently.
Thank you for that advice and clarification. So if a VEDS patient does go to the ER, and maybe this is also for anybody with another connective tissue disorder as well, if they go to the ER with abdominal pain and the doctors can only see constipation and inflammation after the appropriate scans are performed, what would you recommend as next steps?
It's actually really hard to say without seeing an individual scan what inflammation it means. Inflammation where, what is inflamed. It's really hard for me to say. Just to generalize a little bit, one step backwards, if the scan is negative, one, everyone's relieved. We breathe a sigh of relief that there's no big catastrophic event. However, then we come to the frustrating point of, well, my stomach still hurts and there's no answer. In that situation, that's when you should work with either your local primary care doctor or your local gastroenterologist to see what else is going on. Is there constipation? Is there pelvic floor dysfunction driving that constipation and making things worse? Is there, slowing of the entire GI tract, or is it just the stomach, or is it just the colon? Or is this one of the disorders of the gut-brain axis that needs more specialized treatment of the nervous system as opposed to the gut specifically? And I'm intentionally being a little bit vague about treatment of the disorders of the gut-brain axis because it's a little bit of an individualized approach. There are no big there's a handful of medications that are helpful for specific symptoms that have been FDA approved, but there's also a host of alternative kind of therapies within the psychotherapy realm, within the complementary medicine realm that have all had reasonably good evidence in treating these disorders, but really need to be kind of individualized on a patient by patient basis. So it's hard to speak broadly about that.
Okay.
Okay, let me jump in again.
Yes.
I think it's really important to make sure there is no constipation. I'll give you an example. We actually did a study, 120 patients who presented to our clinic with nausea and vomiting. 50% of the patients actually had evidence of constipation that was completely overlooked, and they had either slow transit or a pelvic floor disorder. So even if, and I think there was a question about a 6-year-old child who may not have a very good appetite and is not eating well, first question that would come to my mind is the bowel function regular and normal? That's often where the GI symptoms are arising.
Thank you. And I'm going to go right to that 6-year-old question, because that is my next question here. So this is a 6-year-old child with VEDS who complains of hunger throughout the day, but when they sit down to eat, he only eats a handful of bites before saying that he's full. Would that be an indication that they should be looking into something like gut motility and constipation? Or, you know, at what point would this become an issue for this family?
Yeah, I think like Dr. Camilleri just mentioned, looking into constipation would be one of the first steps. You know, even taking VEDS out of the picture, a lot of our pediatric GI population have constipation as one of their primary driving symptoms, because I think there's like another question for an infant with, you know, how to monitor infant symptoms. And we know that in infants and toddlers and children, their symptoms don't present as specifically perhaps as adults, and the gut is already notoriously non-specific at telling us what exactly is wrong. So in a child, it's hard to pinpoint exactly what it is. And like Dr. Camilleri points out, just because eating is the problem doesn't mean the upper GI tract is necessarily the source of the problem. So it's kind of like a piping system. You have to clear the pipe from the bottom in order to move the top. And so we like to start from the very bottom and make sure everything's working before you really worry about the very top. So making sure there's no constipation, making sure the bowel movements are regular. Trying to figure out, you know, is the child not eating, and this is a little bit out of our realm as adult GI, but figuring out why the child is only eating a little bit. Is it a matter of him feeling full, or is it a matter of, is there pain? Is there a nauseous sensation? And at 6 years old, maybe he'll be able to tell a little bit what's bothering him. Or, you know, is it more that he would prefer to eat smaller meals more frequently? And that might be a reasonable thing to do as well, just to be able to avoid that hunger in between meals. Kids are hard. That's why we're adult GI.
Thank you. I think this is a really great question that I really don't know the answer to as well, and I'm curious. So we talk a lot about avoiding colonoscopy and endoscopy for people with VEDS, and I think LDS as well. Is colonoscopy and endoscopy safe for people with Marfan syndrome?
So I'll quote the paper that quoted that 9.4% perforation rate, okay? When that particular paper looked at the rate of endoscopy-related perforations across VEDS, across classic and hypermobility EDS, and then in Marfan's as well. So that 9.4% actually only refers to vascular EDS patients. The rate of perforation was actually less than 1% in the classic and hypermobility EDS and 0 in Marfan syndrome. Does that mean it's safe for Marfan syndrome? I'm not sure that you can necessarily say that it's safe, but it doesn't look like there's the high rate of reported perforations like there is in VEDS. And similarly, kind of across the other studies that have been done in Marfan, it looks like the rate of symptoms is a little bit less than EDS. So it may be that it's definitely that the rate and risk is less than VEDS less in Marfan's compared to VEDS. How does Marfan's compare to the general population? I don't know.
Okay. And we have a couple more minutes for questions, so we're going to get to as many as we can. what are your thoughts on the Smart Pill GI transit scan for someone with VEDS or connective tissue disorder?
I'm going to defer that one to Dr. Camilleri.
All right.
Something to say.
So the so-called smart pill, which we should really call the wireless motility capsule, is a very accurate test for small bowel and colonic transit. Unfortunately, a smart pill or wireless motility capsule doesn't empty like ordinary food from the stomach. And so it could be retained in the stomach. And often we've seen patients referred for so-called gastroparesis because of a result on a wireless motility capsule. But when we study the emptying of normal food, like a scrambled egg, it's completely normal. So in summary, the wireless motility capsule is accurate for small bowel and colonic transit, but I would not trust the information on the stomach emptying.
Thank you. And one final question, I think, for today. We might be able to hit 2 more. Let's see how long this one takes. There's quite a few in here, though, and rest assured, if we don't get your question answered, you can still submit them to our Help and Resource Center. Are probiotics recommended for connective tissue condition patients with slow motility with constipation?
That's a really loaded question that you're choosing for the last I think we'll summarize it really by saying that the evidence for probiotics has not been studied in a connective tissue population, but the utility of probiotics has more been studied in a general health population or in a general kind of IBS population, and that data is equivocal. So I wouldn't say that we can blanketly recommend probiotics in this population. Is there risk? Actually, I don't know, because the studies that have looked at probiotics don't follow the same adverse event reporting that other drugs that are FDA approved follow. And so there may be adverse events that we don't know about. Use with caution. We're not stamping it.
Okay, so if you summarize all of the literature with these large analyses that have been done, the main symptom that improves with probiotics is bloating and distension. It's not the bowel dysfunction. So the probiotics have, if the best proof is for the sensations of bloating and distension.
Thank you. And I think we might have time for one more, if that's okay with both of you. I want to make sure we get as many as we can. Let me see which one. How, I think you talked about pelvic floor dysfunction, physical therapy. Is that the only way that pelvic floor dysfunction is treated, is with physical therapy, or are there other ways to treat pelvic floor dysfunction?
It's really the best way to treat pelvic floor dysfunction. There are specific, within that category of pelvic floor dysfunction, there can be some issues with pelvic organ prolapse or obstructive defecation that may be amenable to a surgical intervention, but kind of knowing what we know about connective tissue disorders and pelvic floor function, really physical therapy is the best way to go about this. It's, studying our experience with our physical therapy program, we can achieve higher than a 90% success rate with kind of a 2-week session in-house and then 3 to 6 months of homework as you continue to practice at home. And the reason we really love it is because while it is an upfront investment, it's got no risk. There's no side effect. There's no risk of perforation. There's no risk of medication adverse event. There's no hernia risk down the line. It's effective, it's safe, and the effects are fairly long lasting, and so it's worth it. But it's not easy. It's definitely not as easy as taking a pill every day.
Okay, thank you both so much for your time today, and thank you for preparing your presentation, Dr. Wang. I know that this community really, really appreciates everything that you're doing with these GI symptoms. I think it's a huge need in our community collectively. So if your question wasn't answered, please submit it through marfan.org/E3ask. That will bring your question to our help center. It is possible that your question might just need a little bit more specific guidance than what we can provide in a PowerPoint presentation. And be aware that we're getting a lot of questions during the summit, so it might take a little bit extra time for us to get to your question, but we will do the best we can to respond promptly. If you haven't completed the session survey, there should be a session survey in your Whova app. We would love to hear what you thought about this presentation and Q&A. So please complete the session survey when this is over. And feel free to use the Whova app to connect with others in the community. There are a lot of chat boards going on. There's a lot of ways to connect with people. And of course, we do still have about 2 weeks of sessions left. So we hope that you join us again over the next 2 weeks, and use the hashtag E3Summit20 if you'd like to share your experience on social media and let us know what you learned or what you enjoyed. Thank you again so much for joining us, and thank you, Dr. Wang and Dr. Camilleri. It was really nice to see you both again, and everybody have a wonderful Saturday.
Thanks so much for having us.
Thanks for including us. Thank you.
Thank you.